Hello, I am Ron Gasparo, PharmD, and owner of WordCPR.com in New Milford, Pennsylvania. My presentation is entitled, Obesity as a Disease, Easier Said Than Cured. The learning objectives for this program are as follows. Explain the rationale for defining obesity as a disease and how it is a precursor for other major illnesses. Identify those molecular entities that have been used in the past and why they are no longer being used. Interpret the results of clinical studies involving new anti-obesity drugs that are currently in the marketplace. And finally, outline counseling points on how to realistically lose weight. Results from the 2007-2008 National Health and Nutrition Examination Survey show that 68% of American adults aged 20 years and older are overweight or obese. During the period from 1988 to 1994, only 56% of adults aged 20 and older were overweight or obese. The percentage of children who are overweight or obese has also increased. Among children and teens ages 2 to 19, 17% are estimated to be obese based on the 2007-2008 survey. Between 1988 and 1994, that figure was only 10%. The percentage of overweight and obese people in the U.S. is increasing dramatically. In 2004, Utah, Montana, and Colorado were the only states with a percentage of obese people under 20%. The Appalachian states and Texas were the heaviest states. By 2010, only 14 states were under the 25% mark. In June 2013, the American Medical Association reclassified obesity as not just a medical condition or a risk factor for other diseases, but a disease in its own right that warrants treatment. This is a controversial classification that has its pros and cons. What are the pros of the AMA ruling? Obesity is associated with increased risks of a variety of cancers. Obese people are also at higher risk of coronary heart disease, stroke, hypertension, diabetes, and a number of other chronic diseases. Proponents believe that this reclassification by the nation's largest physician organization will improve medical providers' attitudes toward obesity, increase funding for research and treatment, and improve patient care. Rather than seeing obesity as a behavioral problem and a personal failure, obesity will be seen as a disease resulting in greater attention paid by the medical profession to obesity's physical and mental consequences. There could be drawbacks seen by those who oppose the ruling. The possibility exists of unnecessary and costly drug and surgical treatments. Treatments may not necessarily improve patient outcomes. And a disease label may further stigmatize a group that already faces pervasive discrimination. Assessing body weight. Obesity is a condition in which a person has an abnormally high and unhealthy proportion of body fat. How is it measured? Most people use the bathroom scale. But does the scale tell the tale? In a word, no. A scale does not indicate total health. Just because the scale reads what you want it to does not necessarily mean you are healthy. There are several things that the average weight scale cannot reveal because a healthy body weight is a combination of metabolism, age, diet, lean muscle, genetics, and daily activity. To measure obesity, researchers commonly use a scale known as the Body Mass Index, or BMI. BMI is calculated by dividing a person's weight by their height squared. BMI provides a more accurate measure of obesity or being overweight than weight measured only on a scale. Here's an example of a BMI calculator, and they are easily found on the internet. Just plug in your weight and height, and your BMI pops up. This chart shows how the National Institutes of Health interprets your BMI and assigns it to one of these categories. As an aside, I had a patient who was 5 foot 8 inches and weighed 405 pounds. His BMI was over 61, definitely not healthy. What about waist size? All of us have bought a pair of pants, and we are conscious of what our waist size is. But does it always mean we are overweight? Although waist circumference and BMI are interrelated, waist circumference provides an independent prediction of risk over and above that of BMI. Waist circumference measurement is particularly useful in patients who are categorized as normal or overweight on the BMI scale. At BMIs over 35, that is the obese, waist circumference has little added predictive power of disease risk beyond that of BMI. It is therefore not necessary to measure waist circumference in individuals with BMIs over 35. They simply need to lose weight. According to the American Heart Association, one way to preserve cardiovascular health is by maintaining not only a healthy BMI, but also a waist-to-hip ratio, or WHR. WHR is a measure of your waist in inches divided by the measure of your hips in inches. By keeping the range of these numbers low, you can help to lower your risk of disease. Ideally, your waist should be narrower than your hips. For example, if you are a man with a 33-inch waist, your hip circumference should be around 35 inches to be in the low-risk category. If your hip circumference is 35 inches and your waist is 35 inches or greater, you're in a high-risk category. As I said before, obesity can lead to problems. According to the National Cancer Institute, obesity is associated with increased risks of the following cancer types, with endometrial cancer and esophageal cancer leading the pack. One study using NCI surveillance, epidemiology, and end results data estimated that in 2007 in the United States, about 34,000 new cases of cancer in men, 4%, and 50,500 in women, 7%, were due to obesity. Several possible mechanisms have been suggested to explain the association of obesity with increased risk of certain cancers. Fat tissue produces excess amounts of estrogen, high levels of which have been associated with the risk of breast, endometrial, and some other cancers. Obese people often have increased levels of insulin and insulin-like growth factor, IGF-1, in their blood, a condition known as hyperinsulinemia or insulin resistance, which may promote the development of certain tumors. Fat cells produce hormones called adipokines, which may stimulate or inhibit cell growth. For example, leptin, which is more abundant in obese people, seems to promote cell proliferation, whereas adiponectin, which is less abundant in obese people, may have anti-proliferative effects. Obese people often have chronic low-level or subacute inflammation, which has been associated with increased cancer risk. In terms of cardiovascular disease, an obese person has more body mass due to having more body fat. This increased mass means that the person has more blood being pumped by the heart. Therefore, the heart must work harder to shuttle all this blood throughout the body, which causes strain on the heart. The strain on the heart is often heightened when the obese person exerts himself or experiences a jump in heart rate because the heart is working overtime to push the blood through the circulation, and sometimes the heart fails. An obese person can experience heart failure through a myocardial infarction. This is when the heart muscle dies due to not being supplied with oxygen because blood flow is blocked through a fat-clogged blood vessel. Obesity can cause left ventricular hypertrophy or thickening of the wall of the heart's left ventricle. Long-standing LVH can eventually lead to heart failure. Furthermore, obesity is associated with Metabolic Syndrome X, a metabolic disorder that can cause serious lipid abnormalities. It is possible that the LVH and/or metabolic syndrome may explain some or all of the excess in heart failure observed in overweight patients. Metabolic syndrome is a combination of medical disorders that can increase the risk of developing cardiovascular disease. Some studies have shown the prevalence to be an estimated 25% of the American population, and prevalence of metabolic syndrome increases with age. Diabetes and obesity go hand in hand. According to this graph from the CDC, the number of adults in the United States ages 18 to 79 with newly diagnosed diabetes has more than tripled from 493,000 in 1980 to over 1.5 million in 2011. The number of new cases of diabetes has increased since the early 1990s to 2008. From 2008 to 2011, the number of new cases of diagnosed diabetes has plateaued somewhat, although the number of adults aged 18 to 79 with diagnosed diabetes decreased from 1.7 million in 2008 to about 1.6 million in 2011. More years of data are needed to determine if the increase is significant. These maps display the age-adjusted prevalence of obesity and diagnosed diabetes among U.S. adults aged 18 years or older in 1994, 2000, and 2010. In 1994, almost all states had prevalence of obesity less than 18%. In 2000, only 13 states had a prevalence of less than 18%, and 11 states exceeded 22%. In 2010, no state had a prevalence of less than 18%. Almost all states exceeded 22%, and 32 of these states exceeded 26%. Similarly, the prevalence of diagnosed diabetes was less than 6% in almost all states in 1994. In 2000, approximately half of the states had a prevalence of less than 6%. By 2010, no state had a prevalence of less than 6%, and 15 states exceeded 9%. So obesity abounds. According to the CDC county-by-county chart, the prevalence of obesity and diabetes in the U.S. is much higher in the South and Appalachian region than in most areas of the West and Northeast. 81% of counties in the Appalachian region, which includes Kentucky, Tennessee, and West Virginia, have the highest rates of diabetes and obesity. So do 77% of the counties in Alabama, Georgia, Louisiana, Mississippi, and South Carolina. This concentration of cardiovascular risks and diabetes underscores the need for lifestyle and healthcare interventions in these states and pretty much across the United States. How does obesity lead to diabetes? Scientists are now beginning to speculate that it may be related to the number of fat cells a person has. According to researchers in Melbourne, Australia, this is because fat cells release a protein called pigment epithelium-derived factor, or PEDF, which leads to the development of type 2 diabetes. Therefore, the number of fat cells that a person has will be directly proportional to the amount of this protein that is released. Other researchers studying how obesity causes diabetes have come up with additional answers, which appear to relate back to the protein released by fat cells. Originally, scientists focused on the role of insulin and insulin resistance, which is when a person's body needs to produce greater and greater amounts of insulin in order to process glucose in the blood, eventually causing the pancreas to fail from exhaustion. However, it is now known that the protein released by the fat cells is what causes the insulin resistance or desensitization. Recent information indicates that resistance to insulin action and glucose uptake in peripheral tissues is a common underlying mechanism in hypertension and diabetes. New onset diabetes is significantly increased in association with the use of thiazides or beta blockers compared to placebo, whereas treatment with angiotensin conversion enzyme inhibitors or ACE inhibitors or angiotensin receptor blockers or ARBs is associated with a lower than expected frequency. As also assessed in several meta-analyses. In line with this information, the Navigator trial was the first to report a significant preventive effect of the angiotensin receptor blocker on new onset diabetes, evaluated as a primary outcome in a prospective randomized study. Keep in mind that the 5 anti-hyper drug classes offer substantial benefits in reducing cardiovascular complications. However, caution should be exercised when using beta blockers or thiazides as first-line drugs for hypertension in subjects at high risk to develop diabetes, especially in patients with metabolic syndrome. Have patients ever complained to you about putting on weight after they started taking a certain medication? Many prescription drugs can impede weight loss. Discuss any change in treatment with your doctor and encourage your patients to do the same. Here are the most serious offenders. Insulin, especially at higher doses, is arguably the worst barrier to weight loss. Inform the patient that there are 3 ways to reduce his or her need for insulin. Eat fewer carbohydrates, which makes it easier to lose weight. The less carbs you eat, the less insulin you will need. If this is not enough, treatment with metformin can increase the need for insulin in type 2 diabetics. If this is still not enough to get off insulin, suggest using newer drugs like Victoza or Byetta. These reduce the need for insulin and cause weight loss. Other diabetes medications, particularly the insulin-releasing medications such as the sulfonylureas, often lead to weight gain. Drugs such as Avandia, Actos, and Starlix also contribute to weight gain. Metformin does not. Glucocorticoids in their oral form, as opposed to topical or inhaled, are also common culprits. These drugs often cause weight gain if taken for months or years, especially at higher doses. For example, more than 5 milligrams of prednisone per day. Unfortunately, glucocorticoids are often an essential medicine for those who are prescribed it, but the dose should be adjusted frequently so you don't take more than you need. Asthma inhalers and other local cortisone treatments like creams or nose sprays hardly affect weight. So how does prednisone cause weight gain? It can increase the appetite. As you eat more over time, you gain more weight. Also, the body retains more fluid while taking prednisone, causing one to experience water retention and swelling. If the patient has an inflammatory condition that may restrict movement, this can mean the patient is inactive for a period of time, resulting in added weight gain. These other medications can also cause problems. Antihypertensives, especially beta blockers, can cause weight gain. Beta blockers slow the heart rate, which can lead to sluggishness and a decrease in physical activity. And as we mentioned before, the ACE inhibitors and the ARBs can help prevent diabetes, which is tied in with obesity, as we discussed. Drugs for epilepsy may cause weight gain, such as carbamazepine and valproate. A recent trial suggests that zonisamide may also help obese people lose a few pounds when it is added to therapy and nutritional guidance. But people who took zonisamide also reported more side effects, from nausea and vomiting to anxiety and depression. And 2 researchers not involved in the study questioned how much the drug would actually help people in the real world. So although zonisamide is only approved by the FDA for seizures, doctors can prescribe it off-label for non-approved purposes. Prior small trials and anecdotal evidence suggested it might help heavy people shed extra pounds. Several anti-epileptic drugs and drugs used for neuropathic pain are associated with weight gain, including gabapentin, pregabalin, valproic acid, and to some extent, carbamazepine. Others are weight neutral, such as Lamictal, Keppra, and Dilantin. Pregabalin treatment may cause weight gain. In controlled clinical trials of up to 14 weeks, a gain of 7% or more over baseline weight was observed in 9% of Lyrica-treated patients and 2% of placebo-treated patients. Few patients treated with Lyrica, 0.3%, withdrew from controlled trials due to weight gain. Lyrica-associated weight gain was related to dose and duration of exposure, but did not appear to be associated with baseline BMI, gender, or age. Weight gain was not limited to patients with edema. Gabapentin also causes weight gain, but it is only significant in less than 2% of patients. Atypical antipsychotic drugs can often encourage weight gain, especially newer drugs like Zyprexa. Firstly, antipsychotic medication can cause changes in metabolic effects, which may lead to an increase in weight. These metabolic side effects include abnormal glucose levels as well as lipid metabolism that can also lead to diabetes, which is potentially life-threatening. Secondly, atypical antipsychotics can cause weight gain through activation of the hypothalamic AMP kinase associated with the histamine H1 receptor. The hypothalamic AMP kinase is associated with food intake regulation. Thus, the antipsychotic drugs can stimulate appetite. thereby leading the patient to eat more than he or she would normally eat. The patient gets constant food cravings and begins to engage in binge eating. This will naturally result in weight gain. Some antidepressant medications can cause weight gain, especially the older tricyclic antidepressants, as well as newer drugs such as Remeron. The most common antidepressants known as the SSRIs, for example, citalopram or sertraline, usually don't impact weight significantly. Experts say that up for 25% of people, most antidepressant medications, including the popular selective serotonin reuptake inhibitors like Lexapro, Paxil, Prozac, and Zoloft, can cause a weight gain of 10 pounds or more. A review published in the Cleveland Clinic Journal of Medicine stated that while weight gain is a possible side effect with SSRIs, it may be more likely to occur after 6 months or more of use. But SSRIs aren't the only class of antidepressants that may have weight gain as a side effect. Other antidepressant medications, including tricyclics like Elavil and Tofranil, and MAO inhibitors, drugs like Parnate and Nardil, may also cause patients to gain weight with both long-term and short-term use. Although there are a number of theories as to why antidepressants lead to weight gain, the consensus is that both appetite and metabolism may be affected. Patients may swear that they are not eating anymore but still gaining weight, so that tells us there's some kind of metabolic influence going on. Patients may also say that they are not only more hungry and eating more, but that the medicines are encouraging a carbohydrate craving that is hard to control, so we know that appetite also plays a role. While experts may not be certain about why antidepressants cause weight gain, they do know that switching drugs may make a difference. Some antidepressants may be less likely to affect weight. Effexor and Surzone generally do not cause weight gain, while Wellbutrin can cause weight loss. Sometimes switching within the same class of drugs can make a huge difference. Right now, the SSRI, Paxil, appears to be the worst offender, the antidepressant most likely to cause weight gain, while another SSRI, Zoloft, is the least likely. So that's a switch that can sometimes make a big difference for some people. The downside to switching antidepressant drugs is that not every drug works equally well to control symptoms in all people. Antidepressants also simply help us to rediscover pleasure in our life, including food. It may be a situation where someone feels so much better when taking an antidepressant that lots of things suddenly start feeling more pleasurable to them, and food is just one of them. So in this instance, they may actually be overeating and not even realize it. Lithium, used for manic depressive disorder, often leads to weight gain. Some contraceptives also contribute to slight weight gain, especially those that contain only progesterone and no estrogen. Progesterone does cause weight gain as it initially stimulates estrogen, which causes water retention. Water retention will directly add weight to the body, though it will not increase muscle mass. Progestin-only contraceptives, or POCs, are appropriate for many women who cannot or should not take estrogen. Estrogen increases the risk that you will develop endometrial cancer. The longer you take estrogen, the greater the risk that you will develop endometrial cancer. If the patient has not had a hysterectomy, she should be prescribed a progestin, estrogen, contraceptive. This may decrease the risk of developing endometrial cancer, but may increase the risk of developing certain other health problems, including breast cancer. Many POCs are long-acting, cost-effective methods of preventing pregnancy. However, concern about weight gain can deter the initiation of contraceptives and can cause early discontinuation among users. A meta-analysis of 16 studies was performed to evaluate the association between progestin-only contraceptive use and changes in body weight. All of the eligible studies in this meta-analysis examined a POC versus another contraceptive method or no contraceptive. The investigators concluded that overall quality of evidence was moderate to low, and thus there was limited evidence of weight gain when using POCs. Mean gain was less than 2 kilograms for most studies up to 12 months. Weight change for the POC group generally did not differ significantly from that of the comparison group using another contraceptive. 2 studies that assessed body composition showed that POC users had greater increases in body fat and decreases in lean body mass compared to users of non-hormonal methods. Appropriate counseling about typical weight gain may help reduce discontinuation of contraceptives due to perceptions of weight gain. So to wrap up this section, if weight gain is making patients non-adherent to their medications, you can intercede by discussing it with the prescriber, as well as encouraging patients to make lifestyle changes, which we'll talk about later, which leads to our next and most important way to stop obesity. Treatments for obesity can be surgical, pharmacological, or lifestyle changes, or any combination of the above. Public figures such as singer Carney Wilson, New Jersey Governor Chris Christie, and weatherman Al Roker have touted the seemingly instant benefits of gastric banding, or what is also called lap band surgery. The laparoscopic adjustable gastric band, commonly called a lap band, is an inflatable silicone device placed around the top portion of the stomach intended to slow food consumption by making the person seem full. Adjustable gastric band surgery is an example of bariatric surgery designed for obese patients with a BMI of 40 or greater, or between 35 and 40 in cases of patients with certain comorbidities that are known to improve with weight loss. These include sleep apnea, diabetes, osteoarthritis, GERD, hypertension, or metabolic syndrome. The inflatable band is placed around the upper part of the stomach to create a smaller stomach pouch. This slows and limits the amount of food that can be consumed at one time, thus giving the patient the feeling of being satiated. According to the American Study for Metabolic Bariatric Surgery, this is not an easy option for obesity sufferers. It is a drastic step and carries the usual pain and risks, such as infection of any major GI surgical operation. However, gastric banding is the least invasive surgery of its kind and is reversible. Gastric banding is performed using laparoscopic surgery and usually results in a shorter hospital stay, faster recovery, smaller scars, and less pain than open surgical procedures. Because no part of the stomach is stapled or removed and the patient's intestines are not rerouted, nutrients can be absorbed normally. Gastric bands are made entirely of biocompatible materials, so they are able to stay in the patient's body without causing harm. Not all patients are suitable for lap band surgery. Patients who are extremely obese, who have had previous abdominal surgery, or have complicating medical problems may require more invasive surgical approaches. Who are candidates for gastric banding? According to the NIH, gastric banding is indicated for people for whom all of the following apply. People with BMIs above 40, or those who are 100 pounds overweight, or those with BMIs between 30 to 40 with comorbidities that may improve with weight loss. These comorbidities include type 2 diabetes, hypertension, high cholesterol, non-alcoholic fatty liver disease, and obstructive sleep apnea. The candidate should be between ages 15 and 55 years, although there are doctors who will work on patients outside these ages, some patients as young as 12 years. Those candidates who failed medically supervised dietary therapy over the course of about 6 months, who have a history of obesity of 5 or more years, and who can comprehend the risks and benefits of the procedure and be willing to adhere to the substantial lifelong dietary restrictions required for long-term success. Gastric banding is usually not recommended for people with any of the following: if surgery or treatment represents an unreasonable risk to the patient, have untreated endocrine diseases such as hypothyroidism, people that have inflammatory diseases of the gastrointestinal tract, such as ulcers, esophagitis, or Crohn's disease, people with severe cardiopulmonary diseases or other conditions which may make them poor surgical candidates in general. Persons who have an allergic reaction to materials contained in the band or who have exhibited a pain intolerance to implanted devices. People who have a dependency on alcohol or drugs that can interfere with absorption of vitamins and other nutrients. And people who have had severe learning or cognitive disabilities or emotionally unstable people, which may render them incapable of understanding the dietary limitations following gastric banding. Drugs play a part in the treatment of obesity. The FDA approved the first prescription obesity medication in 1947, an appetite suppressant called desoxyephedrine or methamphetamine. Over the next few decades, several more appetite depressants were approved. In 1973, FDA limited all weight loss drugs to short-term use, reflecting concerns about an epidemic of amphetamine abuse and addiction. In 1997, 2 diet drugs were removed from the market because of concerns about damage to heart valves. They were fenfluramine, part of the popular fen-phen, and dexfenfluramine, or Redux. In 1999, orlistat, also known as Xenical, and its over-the-counter form, Ally, came onto the market. Xenical and Ally contain the same amount of orlistat, but Xenical is about 10 times more expensive than the OTC. In 2010, the drug sibutramine, or Meridia, was also removed because of concerns about an increased risk of heart attacks and strokes. And no, the last 2 aren't bad Scrabble letters, they are drug names. In 2012 and 2013, Belviq and Qsymia were introduced to the market, the first anti-obesity medications in a dozen years. Introduced in 1999, orlistat is a reversible inhibitor of gastrointestinal lipases. It exerts its therapeutic activity in the lumen of the stomach and small intestine by forming a covalent bond with gastric and pancreatic lipases. The inactivated enzymes are thus unavailable to hydrolyze dietary fat, which passes through the GI tract and out the rectum. The resulting caloric deficit may have a positive effect on weight control, but it makes for some pretty nasty stools. In 2012, the FDA changed the pregnancy category from orlistat from B, that is, there are no adequate and well-controlled studies in pregnant women, to X, contraindicated. The risks to the fetus outweigh the benefits. Phentermine is related chemically and pharmacologically to amphetamine and to other related stimulant drugs that have been extensively abused. The possibility of phentermine abuse should be kept in mind when evaluating the desirability of including a drug as part of a weight reduction program. Phentermine is a sympathomimetic amine with pharmacologic activity similar to the amphetamines. It has not been established that the primary action of such drugs in treating obesity is one of appetite suppression, since other central nervous system actions or metabolic effects may also be involved. Qsymia is a combination of 2 FDA-approved drugs, phentermine, an antidepressant, and topiramate, used to treat epilepsy and migraines. Qsymia was tested in 2 clinical trials, which included nearly 3,700 obese and overweight patients who were treated for up to 1 year. In clinical trials, the average weight loss of patients taking Qsymia ranged from 7% to 9% over those taking a placebo. 62% of patients on the lowest dose and 70% on the higher recommended dose lost at least 5% of their weight, compared with 20% treated with placebo. The manufacturer will conduct 10 post-marketing trials, including a long-term cardiovascular outcome trial, to assess the effect of Qsymia on the risk for major adverse cardiac events such as heart attack and stroke. The most common side effects of Qsymia are tingling of the hands and feet, dizziness, altered taste sensation, insomnia, constipation, and dry mouth. The drug is in pregnancy category X, Therefore, it is not to be used in pregnant women. How do patients obtain Qsymia? Qsymia is only available at Qsymia-certified retail pharmacies. RXs can also be filled via mail order by select pharmacies in the Qsymia home delivery network. Patients will receive Qsymia every 30 days. Patients may receive up to 5 refills at the prescriber's discretion. If you want to know how to become a certified pharmacy for this drug, go to qsymia-rems.com. Belviq, or locasirin, is believed to decrease food consumption and promote satiety by selectively activating 5-HT receptors located in the hypothalamus. In clinical testing, the average weight loss for patients taking locasirin for 6 to 12 months was approximately 3.5% over those taking a placebo. In studies of patients without type 2 diabetes, about 47% of patients lost at least 5% of their weight, compared with 23% of patients treated with placebo. Locasirin should be discontinued if a patient fails to lose 5% of body weight after 12 weeks of treatment, as it is unlikely that continued treatment will be successful. The drug's manufacturer will be required to conduct 6 post-marketing studies, including a long-term cardiovascular outcomes trial to assess the effect of Belviq on the risk for major cardiac events such as heart attack and stroke. The most common side effects of Belviq in non-diabetic patients are headache, dizziness, fatigue, nausea, dry mouth, and constipation. In diabetic patients, the main side effects are hypoglycemia, headache, back pain, cough, and fatigue. And this drug is also got an X-rated pregnancy category from the FDA, not to be used during pregnancy. Are the new agents better than the older drugs? It's too soon to tell. They have not been on the market long enough. Post-marketing studies have not been done yet, and there have been no head-to-head comparative studies. These agents are expensive. Qsymia and Belviq run about $120 to $150 per month. Probably need prior authorization to get this, and that's before insurance. So over 6 years, the use of these drugs would cost $11,000 to $12,000. Lap banding would be cheaper at about $10,000. In terms of safety issues, adverse events may stop patients from taking the drugs long enough to control lifelong obesity. Remember, these drugs are only adjuncts because diet and exercise are always key in weight loss. And there's a whole bunch of so-called diet pills in health food stores and the like. And here's a chart that talks about them. The fat burners, some studies show mild weight loss. They're generally safe when taken at low doses. Side effects are dangerous. Anxious, jittery feelings. Caffeine, ephedra, guarana, green tea extract are in this category. Carbohydrate blockers. Early studies look promising. Minimal adverse reactions, but there's not enough evidence to recommend it. It could cause GI upset. White kidney bean extract is in this category. Fat blockers. Hardly any side effects, but insufficient weight loss proof. Can't take it if you're allergic to shellfish, and it interferes with medications. Chitosan and alginate are in this category. Appetite suppressants. Some have been used for centuries. There's not enough evidence to recommend their use. They have serious side effects, like liver damage. Hudia, guargum, glucomannan are in this category. And finally, muscle builders or body composition changers. CLA, which is conjugated linoleic acid, may live up to claims. There's minimal side effects when used short term. None actually decrease weight. There's some reports of liver damage with eustenic acid, and some phosphatidylserine or PS supplements are derived from cow brains. Lifestyle. You're probably not exercising right now, but you should incorporate it into your routine, not only for yourself and your health, but also to set an example of good health for your patients. The American Heart Association recommends that adults get at least 150 minutes of moderate or 75 minutes of vigorous physical activity a week. Make a goal of getting 30 minutes of physical activity 5 times a week to keep your body moving. Moderate physical activity includes activities like biking and dancing. Vigorous physical activity includes things like jogging, tennis, push-ups. These will burn more calories than moderate activities, but do the best you can either way. You can do moderate one day, vigorous the next, or over the weekend you can jog 5 miles or play a couple sets of tennis. Change things around, make it interesting for yourself. Even easier ways to exercise are to climb stairs instead of taking an escalator, walking the dog at a brisk pace, and finding a parking space that is farther away from where you are going. Just don't get mugged in that parking lot. Don't think of it as a diet. Think of it as a lifestyle change. Read labels. Eat smaller portions. Avoid processed foods, and eat more foods found in nature. Pastrami and Twinkies are not found in nature. Eat less sugar, less sodium, less fat. I cannot emphasize enough about portion size. I lost over 30 pounds mainly by eating less food, and I really didn't have to give up most of the foods I love. So watch portion size and pay attention to what you're eating instead of watching TV and shoveling food in your mouth. Order what you want in a restaurant, but don't be shy about asking for a doggy bag. So again, with the portion size, the average dinner plate size is huge in North American restaurants. Any of the big chains will just pile it on, pounds and pounds of food. Like I said, smaller dishes help at home. Get a doggy bag. If you're in a restaurant, don't eat all that food in the restaurant. Okay, take the S out of fast food, and what do you get? Fat. You can only imagine what this guy's BMI is. And by the way, most restaurant chains have online postings of the nutritional value of their items on the menu. Before you hit a certain restaurant, check out their websites and see how much fat, sodium, and carbs are in each entree. Can you cheat? Well, in the beginning of your diet, you may crave foods that were previously part of your daily diet. French fries, brownies, chips, double bacon cheeseburgers may pop up in your dreams. If you do succumb to fast foods, order a child's portion or split the meal with a friend. Purchase a single brownie or cookie from a bakery rather than baking an entire batch. Buy a single serving bag of chips to avoid having the whole bag at home. And over time you will realize that you feel better without these foods on a daily basis. Look for slightly healthier indulgences when possible. Dark chocolate is healthier than milk chocolate, baked chips are lower in calories than fried, and brownies made with applesauce allow you to enjoy foods you like in a healthier manner. And you can go out for pizza, you can go out for cheeseburgers every once in a while. Don't give up everything totally. Do it gradually, and then pretty soon you won't even want these things as often. So pretty soon all your hard work will pay off, and you'll have the body you want and be healthier to boot. Thank you.